Okay. So my name's Kate Shea. My pronouns are she, her. I'm the Senior Manager of Clinical Programs at NCSD. I'm really excited to be joined by our speakers today. And before I introduce them, just a couple of reminders. First of all, thank you so much to Hologic for supporting this webinar today. This is the second in a webinar series of three titled STI Awareness. And the third webinar will be in September and it will cover gender affirming care. So more information is going to be released on that in the coming weeks. We will have time at the end of the presentation for questions, a Q&A session, but please do utilize the question box as we go. Type your questions in the Q&A box. We will have Dr. Bukowski and Dr. Schwebke sort of monitoring that throughout, so we'll kind of answer those on the go as well. And at the end, there'll be an opportunity to virtually raise your hand and unmute and ask any additional questions, and we'll answer them in real time as well. So now I'm going to just introduce our speakers and allow them to have the floor. So Dr. Jane Schwebke completed her medical school and residency in internal medicine at Northwestern University. She then completed a fellowship in infectious diseases at the University of Washington in Seattle, where she began her research in STIs and vaginitis. She served as director of the City of Chicago STD program until 1994, when she began her career at the University of Alabama at Birmingham in the Division of Infectious Diseases. While there, she was medical director for the Jefferson County STD program and continued her research in STD and vaginitis. Over the past 30 years, she has concentrated her research on vaginitis, especially trichomoniasis and bacterial vaginosis. She is currently a professor emeritus in the Division of Infectious Diseases at UAB. Very excited to have Dr. Schwebke here. And Dr. Kyle Bukowski is a double board certified obstetrician gynecologist who currently serves as the medical director of Women's Health Diagnostic Solutions at Hologic Incorporated. Dr. Bukowski received his medical degree and completed his residency, in obstetrics and gynecology at UCLA. Following his training, he spent nearly a decade in the nonprofit healthcare space and is the former chief medical officer for Planned Parenthood of Maryland. Dr. Bukowski has dedicated his professional career to ensuring broad access to high-quality medical care, and he harnesses this passion in his current role to contribute to Hologic's focus on improving women's health and well-being through early detection and treatment. Thank you so much, Dr. Bukowski, for being here. So I am going to stop sharing my screen and let Dr. Bukowski share, and we'll get started.
All right, I'm going to be driving the slides. Get these up. All right, looking good. All right, great. Thanks, everybody. These are our disclosures. So as listed, Dr. Schwebke is a consultant for Hologic, Vidal Ortho, Star Pharma, and I am an employee of Hologic, which is an industry partner. And I will pass it over to Dr. Schwebke to get us started.
Thank you so much. Thank you, Kate. Thank you, Kyle. I'm pretty excited about vaginitis. I don't know why it happened, but I am and have been for many years. I just want to share like a little anecdote. When I first came to Birmingham and started working in the STD clinic there, the chief medical officer made the comment, I don't know why we're wasting our time treating all these women for vaginitis in an STD clinic. Well, maybe we can show you why we're doing that. So anyway, vaginitis is a leading reason for OBGYN visits. 21 million women in the US with BV alone. Next. What is vaginitis? Well, I think we kind of know this. It's defined as an inflammation or infection of the vagina and is associated with a spectrum of symptoms, including itching, burning, irritation, dyspareunia, fishy vaginal odor, and abnormal vaginal discharge. So these would be some of the complaints that the woman would come in with. In terms of common causes of vaginitis in the reproductive years, We have bacterial vaginosis, which is about 50%, Candida about 25%, and Trichomonas about 15%. But of course, all of this varies depending on what population you're working with. And there can be combinations of these infections, which I think we've kind of not been recognizing perhaps as often as we should. So let's start with Trich, my favorite. As you know, it's a protozoan, lots of cases. It's interesting that the highest prevalence is among older women, 40 plus. And, you know, people speculate why this is. I think it's because we've never had a Trichomonas control program or adequate screening. So I think this is sort of a cumulative prevalence that these women have probably been living with it for quite some time. It does have consequences, concurrent STIs, maybe an increased risk of cervical cancer. There is data, older data, but I kind of believe it, with a possible connection with preterm birth and low birth weight, and definitely an increased risk of HIV transmission and acquisition. So this is an ancient slide from Joe Losick, who I'm sure you're all too young to remember, at the CDC. But just looking at the comparison between rates of gonorrhea and trich in different age groups, gonorrhea being in the green, trich in the blue. And you can see, obviously, we would expect gonorrhea to be present in the younger age groups, but trichomonas is pretty much steady throughout all of these women. And then and I apologize for this slide, it's kind of cut off a little bit, but this is from a more recent study, which also confirmed that women greater than 40 years seem to have quite a high prevalence of trich. So we shouldn't forget about those women. So what about TB and acquisition of HIV? I think this is a very important and exciting topic. And there have been actually quite a few studies that have shown that Trichomonas increases the risk of HIV acquisition and transmission. This was probably one of the first ones, a prospective study in Kenya, where they showed that trich was associated with a 1.5-fold increased risk of HIV acquisition after adjusting for potential confounding factors. So this is acquisition. So this is, you know, new cases. It's not like they had HIV and trich all along at the same time. And this I thought was an interesting study. This was an in vitro study. They looked at the metronidazole treatment effect on vaginal HIV RNA in women with trich. So the hypothesis was if you treated the trich with metronidazole, you would decrease the viral shedding of HIV in the genital tract. And indeed, they showed that, and quite dramatically. You see pre-treatment HIV RNA levels and then post-treatment HIV RNA levels. So I think that's very important for public health. What about pregnancy? Again, older data, but a higher incidence of preterm birth reported by Minkoff and Koch, and also low birth weight. In terms of treatment, I'm sure you're all familiar with this. Metronidazole 500 milligrams POBID for 7 days has now replaced 2 grams single dose in the CDC treatment guidelines based on a recent clinical trial by Kissinger et al. So, you know, we're kind of between a rock and the hard place here, because the 2-gram single dose was kind of preferred because it did have decent treatment outcomes and had better adherence, obviously. But we do have data now that perhaps we should be moving to the 7-day dosing. Alternatives, tinidazole or secnidazole, which can be used 2 grams in a single dose. Secnidazole was recently approved in the US, but both of these are much more expensive than metronidazole. And aside from the single dose with secnidazole, I'm not sure there's a huge advantage there. Of course, it is an STD, so we want to treat the partners. This is kind of a conundrum, because now we're saying, well, we should treat women with 7 days, but we really don't know what to do with the male partners. So currently it just states that they should be treated with a 2-gram single dose. And this was a fun fact for me, which I learned way too late, but was out there in the older literature, and it showed that about 50% of infected men actually have spontaneous resolution. And I think that's just because the urethra is not such a great place to hang out for these bugs, whereas the female genital tract is a lot more interesting for them. So sometimes we encounter resistance, and these are the options. If you fail routine dosing, you can see them listed here. I have treated several women actually who had tried everything and nothing worked. And this was the last bullet refers to a pretty intensive regimen using paromomycin cream, vaginal cream, for 7 days. And also, I should have added on here high dose tinidazole for 7 days. I mean, sorry, both of these would be for 14 days. I apologize for that. Okay. All right. Well, what about BV? Oh my gosh, where do I start? Okay. So I think you're all familiar with these, stop it, Kyle. Are all familiar with these gram stains. Looking at on the left, well, it's my left, I don't know, normal vaginal flora gram stain, you see moderate numbers of large gram-positive rods, which represent the lactobacilli, which are definitely our friends. And then it moves to intermediate, where we still see some lactobacilli, but we start to see morphotypes that look more like Gardnerella. And then, of course, BV, which is, you have really a hard time finding a lactobacillus morphotype. Tons of GVAG morphotypes, and probably there are Bacteroides morphotypes in there as well. And it's this huge increase in the number of these bacteria as well, which is really impressive. So most common cause of vaginal infections, discharge and odor, but about half of women really don't have symptoms or don't recognize symptoms. On examination, this homogeneous milky white discharge, the etiology is controversial and unknown to some, but I kind of think I know where it comes from. And treatment is successful in only 70 to 80%. And honestly, those are very high figures in my experience. I think it's more like 40 to 50%. And recurrence is frequent in some women. So we already alluded to the fact that there's a marked decrease in most lactobacillus species, our friends. Gardnerella vaginalis is uniformly present in high concentrations. And then we get this abundance of strict anaerobic species, which interesting, can vary between individuals with BV and probably are the cause of the fishy odor that women sometimes experience. So this was one of my favorite all-time studies. It's old now. It was by Swidzinski et al. And this guy started out looking at biofilms in the GI tract, and he morphed into looking at potential biofilms in the female genital tract, specifically among women with BV. And I think it really turned the tide on how we think about BV. In these photos, if you look at the orange photos, the two on top and the one on the bottom left, and you see that really bright, it almost looks like lava, a really bright orange. That's a probe, a fluorescent probe for Gardnerella. So it shows you very nicely how there's this confluence of Gardnerella on the epithelium of the vagina. And indeed, they found that Gardnerella composed 60 to 90% of the biofilm mass. This bug Adipobium was found in 70%, and Adipobium is very interesting. We still, I think, don't know a lot about it, but it has been implicated in terms of promoting markers of inflammation. And then lactobacilli were few and far between. So this is what my patients would ask me: how the heck did I get this? So there are various hypotheses that I've heard throughout the year. One is it just happens. Maybe vitamin D, stress. Thong underwear was one of my favorites, etc. It's genetic. I don't think there's any evidence for that. It's transmitted sexually via this polymicrobial chunk of bacteria, or a founder organism, which is the true pathogen, perhaps Gardnerella, is transmitted sexually. This is just to remind you, risk factors for acquisition of BV. This was an older study. But if you look, you can see that having a new partner since the last visit where they did not have BV and have now acquired it was very significantly associated with acquisition of BV. And then this study out of Australia, Katerina Bradshaw et al., I thought this was really interesting because they looked at practices associated with BV recurrences, not new BV acquisition. And they found that it wasn't the new sex partner in these women that was causing the recurrences. It was the same old sex partner that was associated with these BV recurrences, suggesting, as people have kind of thought all along, that maybe there's this ping pong effect. So the woman gets it, she transfers BV associated bacteria to the male, he transfers them back, etc. Complications of BV, some similar to TRIC, preterm birth, acquisition and transmission, again, of STDs and HIV, post-gynae surgery infections, post-abortal PID, recurrent UTI, and as I said before, treatment options are really not that successful and recurrence rate is high. I wanted to, I can't possibly have time to go through all the studies that showed a relationship between BV and STDs, but this was a little study we did way back when, where we took women who had BV and we randomized them to BV treatment and twice weekly prophylaxis with metronidazole gel, and looked at the acquisition of chlamydia infections. And in the two groups, the other group was just observation. And in the two groups, the observational group clearly had more incidences of chlamydia infections than did the BV group. So it was a small study. It probably needs to be replicated with a larger population, but I always thought it was of great interest. Treatment of BV. Nothing great. There's metronidazole and clindamycin, and that's about what we're stuck with. I want to say a few words about Gardnerella. It's kind of my favorite bug. It's present in all women with BV. It's a fastidious, facultative anaerobic bacteria. It is a facultative anaerobe, and as such, in terms of its metabolism, it lowers the redox potential. That's the amount of oxygen present in the vagina for microbes. It lowers that redox potential when it's present. And it's also proteolytic, which means it breaks down proteins instead of sugars for its metabolism. And doing so, it raises the pH in the vagina. And we know that BV is associated with higher pHs. And this was just a little schematic that I've always loved, which shows that, again, what I said, GVAG produces amino acids because of its metabolism. And then it's interesting that one of the key anaerobes in BV, Prevotella bivia, feeds into this by producing ammonia, which GVAG in turn utilizes. So obviously I'm not going to spend time on this. I think you'll have copies of the slides or have access to them, but it's kind of my schematic representation of how the heck you get BV, even starting with the birth of the female and the birth of the male. Next. In terms of males, it has been isolated from male partners of women with BV, and that was a long, long time ago by Gardner and Dukes. But other people have also found this to be true. Sharon Hillier found Gardnerella anaerobes in semen samples. Peter Piot showed that biotypes of GVAG isolated from women with BV and urethras of their sex partner were identical 90% of the time. And then we found Gardnerella detected by PCR in 25% of men attending the STD clinic. And I should say that in women in our STD clinic, the prevalence of BV was like 50 to 60%, so huge. We did do this little study of the treatment of male sexual partners of women with BV, metronidazole for the men versus placebo. All the women got treated. Their partners received metronidazole or placebo. And even though the study was technically a negative study, when we broke it down by behaviors reported by both partners, one partner, or neither partner, you can see that reported condom use at the last sexual encounter by no partners was, I'm sorry, I'm getting this confused. Treatment adherence and condom use was not associated with recurrent BV. Next. Co-infections. So briefly, Hologic actually sponsored this study, vaginitis and STI study. They looked at a lot of women with symptoms of vaginitis. And they assessed the associations of STI infections with vaginitis as determined by NAT diagnosis, clinician clinic diagnosis, and the usual routine laboratory reference standard diagnosis, not NATs. And then you can see, I'm not going to go through the data analysis here. I think it's pretty clear how the study was conducted. You see 21 sites, lots of symptomatic women, a bunch of vaginal swabs collected, and they looked at those different ways of diagnosing STIs and vaginitis. So this just looks at the vaginitis diagnosis by NATs. And you can see that a third had BV only, 16% had yeast, only 2% had trich in this cohort, 18% had mixed infections. And those could be BV, trich, BV, Candida. About a third of these women were negative for all of those, even though they had symptoms. And this looks at the STI prevalence by NATS diagnosis compared to the clinician vaginitis diagnosis. So this would be point of care testing, okay? So your wet prep, basically. And what they found was that 45% of STIs are in women with clinic diagnosed BV. 93% of these were MGENT and or TV. They did test for MGENT in this study, and they did consider that to be an STI, although I must say that could be a little bit controversial. 1 in 4 women with this clinic BV diagnosis had an STI, compared to 1 in 10 women who had a yeast infection and an STI. So quite a difference there. This is the same thing, NATS STI prevalence, but this time by laboratory vaginitis diagnosis. And for the study, this was things like Nugent score, yeast culture, TV culture, things like that. And they found the same thing, that if you had BV, you were highly more likely to have an STI, especially MGENT. And this was just another way of looking at that. But this is in terms of, okay, STI diagnosis by NATS and lab diagnosis by NATS for candidiasis. And we still see that if you're BV positive, no matter the combination, you're going to be more likely to have an STI than if you're BV negative. So this was a summary. I don't think I need to go through all that. Most of the STIs were found in women diagnosed with BV, CV, or TV, but almost half, 45% of all STI infections were in women with BV alone. And I think this has important implications. And this gets back to when 30 years ago, I started at that STD clinic in Birmingham. And the medical officer said, why are we wasting our time treating all these women for vaginitis? Well, maybe we weren't. Women diagnosed with BV by any method should be tested for chlamydia, gonorrhea, and MGen, regardless of other risk factors. And that indeed has been stated in the CDC STD guidelines, but I'm not sure that we're all following that advice. And this is just a summary. STIs and candidiasis, there does not appear to be a parent relationship. When you look at women who have VVC, they still have a lot of lactobacillus dominant vaginal flora. So it's not really a biological risk factor, whereas where we talked about STIs and TRIC and BV and STIs, there clearly is evidence to associate those two with STIs. And I think that's my last slide.
Yes,
and I'm going to turn it over to Kyle. Is that right, Kyle?
Yes.
Okay.
So yeah, thank you so much. I just love hearing you talk about co-infections because I worked at Planned Parenthood for a decade before coming to Hologic, and I think we saw the same thing where BV is not categorized as an STI, but the overlap in terms of sexual risk factors or concurrent STIs was very obvious. And so understanding the biology of that more, I think is fascinating. I'm going to take us through Candida quickly, and then we're going to talk a little bit about diagnostics. So, Canada's, I guess, not the most exciting one. BV is so fascinating because it's not a single pathogen sort of infection. Trich obviously is, Candida but Trich is categorized as an STI as well. So there's a little bit more understanding about risk factors there. So when we talk about Candida species, really this is a normal colonizer of the vagina that can basically overgrow and cause inflammation and essentially infection, causing symptoms. We have our kind of classic symptoms: burning, itching, abnormal discharge on exam, hallmarked by that thick, hurdy discharge that patients are noting and complaining of. And this is our second most common cause of infectious vaginitis after BV. This obviously affects a ton of people, right? Over 3/4 of women will have at least one episode of yeast infection in their lifetime. And what can be challenging about this, particularly for us clinicians, is that many patients will self-diagnose and use over-the-counter treatment, which kind of muddies the picture whenever we're trying to understand the patient does show up to us, what they've already used, did it get better or worse when they used it, was it really a yeast infection to begin with, which then also makes this concept of recurrence quite high, because if you really never diagnose officially the first infection, you use some kind of over-the-counter treatment or maybe an influenza treatment, and then they have persistent recurrent symptoms, it's really hard to understand what's happening, and which is why up to 5% of women will report recurrent yeast infections. So similar to BV and other things, it really depends on the clinical picture when somebody's coming in to understand what your kind of pre-test probability is. So a couple of things. One, it's quite uncommon outside of reproductive years. So less common in prepubescent girls and postmenopausal women for yeast. And so probably being overdiagnosed in those populations if patients are being diagnosed with that. And while this is not an STI, as Dr. Schwebke is pointing out, probably important that we are always thinking about STI testing and offering STI testing anytime somebody's coming in with vaginitis, because they're going to present with the least similar symptoms that you can't necessarily rule out a infection. And we also know that co-infections and mixed infections occur quite commonly. And then last is for most uncomplicated yeast infections, there's no precipitating factors. Kind of getting back to the thong underwear listed as a potential cause for BV, there's so many times where I remember we used to have patient education that was like, avoid like wearing bathing suits too long and spending time in hot tubs and all these things, but we know that this is rarely caused by some precipitating behavior. It's just that yeast already lives in the vagina, and if you disrupt that kind of microbiome and overgrowth, for whatever reason, overgrowth occurs, the patient can become symptomatic from that. Most infections are Candida albicans, right? This is the most prevalent, up to 90% of Candida vaginitis cases, but we do need to think about the fact that Candida glabrata is second most prevalent and can be associated with azole resistance and may be a little bit more challenging to treat, which is why we should always be considering culture for patients who are truly presenting with persistent or recurrent yeast infections to make sure that we are appropriately identifying the species and any kind of susceptibility testing. All right, so that is yeast. So we're talking a little bit about diagnostics, because I think this is where many of us struggle with what's available to us in giving patients accurate answers for what's going on with them. And so I was going to start with a case to get us started. So we have a 26-year-old G0 presenting with increased vaginal discharge, odor, and irritation for 3 days. The patient has tried an over-the-counter yeast medication without relief. Patient reports she has a new partner in the past 3 months and uses condoms most of the time, but also relies on oral contraceptive pills for contraception. Pregnancy test is negative. Patient had STI 6 months ago, so before this partner, that was negative for chlamydia gonorrhea. Had a PAP 6 months ago, that was normal. And on exam, you see thick white vaginal discharge and erythematous vaginal, not vaginal walls. Cervix is non-friable and without lesions. So how would you evaluate this patient at this time? Would you diagnose and treat them based off history and physical exam alone? Would you perform point-of-care testing for vaginitis in your office, perform lab-based testing for vaginitis, or other? I'll let you think about your answer. So let's talk about office exam first. So any patient who is presenting with vaginitis complaints really should have an exam, right? So you need to obtain a history, making sure that you're assessing any kind of risk factors such as medicine, hygiene practice, sexual behavior, and other partners. And typically the patient should have an exam, right? Looking at the vulva, the skin around the anus for signs of inflammation, as well as the appearance of the vaginal walls and the quality of the vaginal discharge. And most likely you're going to need to collect some of the vaginal discharge for assessment. What is really important to understand is we are not good as clinicians at diagnosing vaginitis just based on physical exam and history alone. We are often quite poor at it, which often contributes to incorrect treatment and often of the wrong organism based on that. And so because there's huge overlap in the types of things that can be causing these infections, right? BVs, trich, chlamydia, gonorrhea, MGen can all have very similar presentations. We need to use some kind of diagnostics to better understand what may be causing these infections. So this is kind of the list of things that you could be using as part of your testing. So wet prep, if you're doing microscopy in the office, you can be using wet prep. Benefit here is that you can look for BV, CV, and TB all in one slide. It's point of care, which is nice, but it requires training. It requires the ability to have microscopy, and sensitivity can be low depending on the quality of the prep and the skill set of the person reviewing the slide. So AMSL is essentially additional criteria added on to a wet prep to evaluate for BV. Specifically, it is point of care, but again, requires training and has some interoperator reliability issues. Gram stain with Nugent is the gold standard for diagnosing BV. So this is taking a specimen to the lab, staining it. Benefit here, it is quite sensitive. Some of the problems, though, is it does have this intermediate vaginal flora score, which can be challenging to understand management, particularly for symptomatic patients. Direct probe, so this is a direct DNA probe, non-amplified. This can look for BV, CV, and TB, looking for a single target. It is designed to be point of care, but there is still some subjective interpretation of the reagent kind of color on some of these, so there can be some challenges in its sensitivity. Yeast culture is gold standard for diagnosing yeast infection, and really only typically used in somebody who is having persistent recurrent symptoms because you get the additional susceptibility to antimicrobials. And then lastly is NAT, right? So our nucleic acid amplification testing, done in a lab-based setting and can be used for BV, CV, and TB. And I would argue that NAT is really should be thought of as the preferred method for diagnosing most of these infections, particularly if you don't have access to microscopy or your microscopy is inconclusive or negative for things like TRIC. So benefit of NAT testing, you have the ability to consider multiple targets, right, at one single time. So you can test for multiple things. You can add on STI testing as well for chlamydia gonorrhea off of the same collection. Depending on which test you're using, you can either use clinician-collected or self-collected swabs, depending on the approval of the assay and all of that. And for BV specifically, what I like about NAT testing is, as Dr. Shwebke pointed out, BV is the shift in this large vaginal flora, right? And there's some highlights, right? We know Gardnerella becomes predominant. We know Lactobacillus significantly decreases, but it's not the presence or absence of a single organism, but it's this larger shift and looking at multiple targets at once and their relative concentrations becomes important for kind of turning that Nugent score picture into a molecular assay to identify what is happening to the flora makeup of the vagina, particularly in BV. Also with NAT testing, you can specifically look for other Candida species like Candida glabrata, which then is associated with azole resistance and may prompt you to either use a different treatment pathway or move to susceptibility testing with culture more quickly. ACOG and the CDC both recognize that NAT testing is the preferred gold standard for diagnosing TRIC, just because wet mount microscopy, the sensitivity is about 50%. As that specimen cools down to room temperature, and if you don't have a ton of motile organisms, you can definitely miss TRIC on a slide. If it's there, it's TRIC, right? Specificity, very good. Obviously, if you see TRIC on a slide, everybody in the clinic is going to have to run to the slide to see it, particularly if you have learners in your clinic. We've all done it. We've all run to a slide when there's TRIC in the clinic. But if you don't see it, it doesn't mean it's not there. So I can tell you my practice, when I was at Planned Parenthood, we did do wet mount microscopy just because we saw so many patients with vaginitis complaints. But we always ordered a NAT test if they're were symptomatic and their specimen was negative for TRIC, just because we knew that poor sensitivity. And we had a pretty high pre-testing probability just given our patient population. Other benefit of NAT, definitely helpful at identifying mixed infections, right? When both BV and Candida or BV and TRIC are present, having that molecular-based test is much easier. My personal issue with microscopy, it is good, is I feel like you go into it with so much like confirmation bias. Because you listen to the patient's story, they're telling you that they have BV, you do the exam, you look at the discharge, and then you're looking at the slide, and I feel like sometimes you're already looking for things, or maybe kind of confirming that diagnosis. And so I think there is some benefit in molecular-based testing to make it a little bit more objective. That being said, when you have a patient who's symptomatic from vaginitis sitting in front of you, you want to get them some relief as quickly as possible. And so I think the big challenge for NAT testing is having to send a specimen to the lab and wait for a result for a symptomatic patient can be hard. It also, if you're already relying on point of care testing. So in terms of sensitivities, so this is just looking at the package inserts for multiple molecular-based tests that are on the market. You can see that NAT, either looking at other nucleic acids or DNA PCR, both have a much higher sensitivity than direct probe, which is and they're looking at multiple targets, right? And looking at that kind of shift in the vaginal flora, as opposed to direct probe, which is just looking at Gardnerella in a non-amplified form. So the sensitivity does improve when you amplify and look for more targets, particularly when we're talking about BV. I'm going to present data that is Dr. Shwebke's data from her studies. But this is, again, just looking at NAT-based test, clinician diagnosis, and in-clinic testing. And you can see for BV, Candida species, and TRIC, superior performance of NAT at identifying those infections compared to in-clinic testing alone or in-clinic plus clinical diagnosis. And then when we talk about co-infections or mixed infections of the other vaginitis types, you can see that when you have a mixed infection that's identified by a molecular test, clinician diagnosis really is quite low at catching both organisms that patients are presenting with, right? So you're definitely going to do better with a NAT test when you see a Candida BV infection or a Candida trick infection or BV and TB together. And so, again, this just points out that having robust objective testing, particularly when we know that these mixed infections occur, becomes important because you want to get the diagnosis right so that you can treat the patient appropriately, which I think also contributes to why we see such high recurrence and persistent symptom rates, is because depending on the sensitivity and the quality of the test that we're using, even if it's empiric, right? At the time of initial diagnosis, we're going to create a lot of angst for our patients and impact on quality of life if we're not getting it right as early as possible. So this is just, again, showing ACOG, CDC both recommend NAT testing for trick diagnosis specifically over wet mount or direct probe. So we're going to return to our patient, and based on the patient's history, physical exam, prior over-the-counter treatment, you decide to send a NAT test for vaginitis. So you're looking for BV, yeast, trick, as well as bacterial STI, since the patient has a new partner and is symptomatic. Patient's results return positive for BV and CV. All other testing is negative. And so how would you manage the patient at this time? So we talk about treatment a little bit. This is getting back to what I was just mentioning. Misdiagnosis and inappropriate treatment are quite common. So misdiagnosis occurs even when using Amsel criteria for BV. We see that 50% of women with yeast infection are misdiagnosed with clinical and conventional testing approaches. And over half of women who have a vaginitis diagnosis or receive medication are not even tested, right? There's no associated testing on top of it. It's just empiric based on exam or history alone. And then again, because of that decreased sensitivity, we know that some patients with and especially some patients with direct probe will kind of get false positives for BV. So this misdiagnosis piece is really challenging because people are either being told that they have an infection that they don't have, or they're being told that their vaginal discharge is normal when it's in fact not. So that then, of course, is going to lead to inappropriate treatments. So we see almost a third of women without lab confirmed infection are receiving some form of antibiotics or antifungals, which may further be disrupting their vaginal microbiome. And 47% of women with vaginitis receive one or more inappropriate prescriptions based on the actual gold standard test that was taken at the time of their assessments and compared to what they received. So you need to be thinking about this whenever we're managing and really trying to get it right from the beginning. So Dr. Shwebke already talked about management for BV and trick. This is just a reminder from what's currently listed in the CDC treatment guidelines. And then for yeast, which I covered, you're going to use some antifungal, either a vaginal cream of some azole or oral fluconazole. There are a number of new yeast medications coming on the market or antifungals, but I have not personally used them. They definitely can be more challenging to get coverage, or they may be expensive. And there are a lot of cautions about any kind of use in pregnancy if you're managing pregnant patients, since they just don't have the safety profile established. One topic that I dealt a lot with was this concept of recurrent BV or persistent BV. I had so many patients coming in 3-4 times a year with BV, obviously incredibly frustrated. So this is the long list of possible things you can do for recurrent BV. And I like your "there's no good treatment options" point, Jane, about BV, because when you look at the CDC treatment guidelines for recurrent, it's pretty like you can try any of these things and see what works for the patient and what they're actually going to be compliant with, right? So you could do metronidazole 750 milligrams vaginally twice weekly for 3 months. You could do Metrogyl twice weekly. Sorry, those are repeats. You could do oral metronidazole 2 grams and oral fluconazole orally monthly for every 4 to 6 months. And then you can do kind of the one that I often would use, which is like the initial treatment of their infection, boric acid for 3 weeks to kind of maintain a more acidic pH, and then do the suppressive therapy after that. But this is like really intensive for patients. It can be really frustrating. And so many times patients are like, I just want my vagina to be normal. Like I just want it, like, I'm so tired of having to deal with this. And so the impact on quality of life is really challenging. So, but that will take us to the end. So really have enjoyed this conversation. I totally agree, and unfortunately not surprised that a CMO or somebody was like, why are we talking about vaginitis in an STI clinic? But this is a huge impact on women's lives. And I think for a lot of us who do this, it's treated as kind of bread and butter gynecology. And the more that we understand these infections, the way that we test for them and the way that we treat them, and how much more work we still have to do to understand these things better and come up with better testing and therapeutics for this, I think it just gets more interesting. I can fully admit I had no concept of biofilm as a driver of BV until a year or two ago. Like I was never taught that in residency or training. It was just like it's Gardnerella and you're going to use metronidazole and like that's it. And so the more that we understand this, and particularly more that we understand this concept of co-infections with STIs and mixed infections with other vaginitis causes, I think is going to make us more astute diagnosticians, understanding what's happening with the patient, adequately and accurately diagnosing them, and then providing treatment that is really tailored to what they're experiencing. So I very much appreciated and enjoyed getting to learn from you, Dr. Schwebke, and getting to share this information. And we would be absolutely happy to take some questions. I don't see anything in the Q&A yet. I know the chat is disabled, but if you guys can drop questions in the Q&A, we would love to answer them or hear about some of your particular wins or challenges managing vaginitis in your practice settings.
I have a few comments. First
Yeah.
and foremost, I'm so embarrassed that I don't even remember what my own study was in terms of male partner treatment. But every time I show that slide, I don't know, I get confused. Anyway, the bottom line was if both partners, the male and the female, reported condom use at the last sex, that was a significant pointer to lower recurrences of BV. And the same was true if both partners reported good adherence to the medication protocol. That led to lower recurrences of BV. So I'm really sorry about that. But I have a question for you, Kyle. In your case.
Yes.
So you found both BV and yeast in your patient with NATs. How do you know which one is causing the symptoms? How do you reconcile that with the continued, I think, ridiculous stance of the CDC on not treating asymptomatic BV?
Yeah, that's a great question. I would say I'm a big fan of shared decision making. So I probably would one, talk to the patient or look at my notes, again, assuming I'm getting this result a day or two later and try to decide, and I just said, like, don't trust empiric, but we're all very experienced clinicians. And so depending on what they're describing, and if these patients come back and like, this is BV, I have BV again, I know it's BV, maybe I'll start there and then, check in and as they're completing therapy and see if their symptoms are getting better. I may offer them both an antifungal and BV treatment. But that is what becomes hard is even though because now you have this really sensitive assay that can identify both of these infections, doesn't necessarily mean that both are happening. And when you look at the data with MGen, right? And I appreciate your comment about MGen of like, it's a lot of STI, which is MGen, but we don't have good therapeutics for MGen. And so, we take ourselves down a challenging road, identifying MGen, particularly when we don't know that it's truly symptomatic, because we have really high macrolide resistance in MGen and we don't have good therapeutics. So I think it's back to the same point. I guess the one nice thing is, for the most part, BV and Candida albicans are relatively susceptible organisms, or the treatments are relatively benign, but it gets challenging. I agree. And I don't think I have a good answer to how I would suss it out, but it definitely be a shared decision-making conversation with the patient about what they want to do. Looks like we have one question in here. So in a
And
public health,
before,
sorry.
sorry, just before you answer that question, I also want to remind folks if you would like to actually just come off mute and participate in conversation, you can use the raise your hand feature and I can unmute you. But otherwise, yes, please do put questions in the chat.
All
Sorry,
right.
Dr. Prihowski, go ahead.
Yeah, that's good. I like that. I love real-time interactions, so that's nice. In a public health department STI clinic, we see vaginitis symptoms all day, every day, and do point-of-care wet mounts. To send for NAT incurs extra costs and a delay in treatment, especially when there are barriers to getting to clinic. So ask them to wait a couple days for results. Treatment might be tricky. Thoughts, best practices. I agree. I worked at Planned Parenthood for a decade. I like to think of us as a sexual reproductive health urgent care. And so this has always been my biggest challenge with trying to implement NATs is or lab-based testing of any kind is one, patients are used to getting their treatment, their answer and their treatment the same day. The cost of having some kind of follow-up team that's going to review those results and call the patient and send in a prescription can be challenging. And so I think it's hard for us who do high volume of this, but definitely, I mean, this is really what I hear pretty commonly used in most private practice, GYNs, OB practices, like they don't have microscopy in their office. And so this is what they're using. They're doing lab-based testing. And so I think the volume piece becomes challenging when it's not an all-day, everyday thing. It becomes much easier to utilize these. But when it does, you need a really slick system for follow-up to be able to make it work. At least that was my experience. I'd love to hear your thoughts, Jane.
Yeah, I mean, I agree. I mean, I think that's the real downside to NATS testing is that what are you going to treat her with then? I mean, I guess one approach would be to do a wet prep and identify something to treat her that day. And if you had the money, send the NATS test as well in case you miss something, because we know the wet prep for trick, for example, is not all that sensitive. So I don't know. I think that might be an approach. But again, you're right. I mean, private practice, they don't have microscopes. Even if they did, the microscopes are 100 years old and they don't know how to use them.
Yep.
So it really is a conundrum, and I think, I mean, the ideal thing would be to have a point of care NATS test or a point of care test that's as sensitive as NATS, but we're not there yet.
Yeah. And somebody said, you mentioned wait time is a challenge. What about others? I think of cost. I mean, cost is definitely one of them for sure. I mean, I would say trick coverage is pretty decent for NAT just because the pore sensitivity. I know I worked in California and Maryland and NAT was covered for symptomatic women in California. And we worked really hard to get it covered for asymptomatic screening for when appropriate for the population prevalence for trick. It's definitely a little bit harder for coverage for BV and yeast depending on where you're working and what type of patients you're taking care of. Somebody else said we all see patients coming back within a couple of weeks of treatment complaining of recurrent persistent symptoms. So for those patients, NATs would be ideal, but still logistically challenging. I agree. I mean, I think kind of if you have a cost issue or a logistics issue, use it when it's most helpful to you, right? So if you are doing microscopy all day, every day, you have really skilled clinicians doing it, then using a NAT test for when you have the recurrent, persistent, or confusing patient is going to cost control, but still maybe give you the accurate diagnosis because there is cost on the other end by not getting the diagnosis right? These patients, there's loss of time and money for these patients coming into the office multiple times with their persistent symptoms. There's quality of life impacts. There's your time providing treatment for things that aren't, truly what's causing their symptoms. That there is cost to the larger healthcare system when we're not getting it right to begin with. But those are obviously more nebulous than the bottom line of how much a test costs and how much a patient or your practice incurs by ordering it, for sure.
Well, I have more comments.
Yeah, please.
Um, I just wanted to bring this up that in the CDC guidelines for when you suspect trick resistance, they tell you to send the isolate to CDC for sensitivity testing. Well, you would have to send a live bug. And so most people don't have access to a trichomonas culture. And even if you did, getting it shipped to the CDC still alive is an incredible challenge. You'd almost have to get on the airplane and take it with you.
Or
So,
bring the patient.
yeah, or take the patient.
Would you like to go to Atlanta?
So you could babysit it. But in our experience, there really was not a correlation. It was kind of interesting in terms of treatment response and susceptibility testing. It kind of went both ways. Like if it was really resistant by sensitivity testing, a lot of times the women would be cured with regular treatment and vice versa. So I have to I don't know, think about how useful that particular guidance is.
Yeah, I struggle with the lack of, non-nitramidazole treatments in
Yeah.
patients who report true nitramidazole allergies. Um, they're like, nope, I got hives. When I took Flagyl, I'm like, oh, this becomes really hard. Like, I don't know what to do. Like theoretically, the CC says desensitize them, but the patients I was taking care of rarely had commercial insurance or access to an allergist to do desensitization. So I just was like, it's hard enough to get pregnant patients desensitized for penicillin and syphilis. So I always find that very challenging. Um, Getting back to your comment about the condom usage and partners being on suppressive therapy, which I never thought about putting a partner on suppressive therapy for somebody who was like really motivated to do it. It's kind of interesting. But you had shared that story where people will be like, I only get BV with X partner, right? Like people know the partner that gives them BV.
Yeah.
Or when they stop using condoms, they know that they're going to get BV. I guess one thing we didn't talk about here, but it's interesting is I know there's some studies going on with Phexxi, the vaginal pH modulator that as a contraceptive came on the market 3 or 4 years ago. But I know that they're looking at potentially reduction in STIs with users of their contraceptive gel because
Interesting. I
yeah.
didn't know that. And is it just a pH adjustment?
Yeah, it's and I can't think of what acid it is. But it's basically like a creates like a film in the vagina and it's a pH that they market as a pH modulator that's spermicidal, but they're also looking at potentially decreased STI acquisition in users. Like it's again their marketing material, so I haven't seen actual data, but I know that they were looking at that. And I've gotten questions before when talking about vaginitis about whether people like, should I recommend that to my patients who have recurrent BV and things like that, which again, we don't have any data yet to say, but it is interesting.
Well, we did a study years and years ago with Acigel, which is, I don't know if it's still available OTC, but I think it is. And for BV, and it didn't work at all. But if they have like a sustained release, that I doubt it'll work, but it might be interesting to see.
Yeah. Yeah. I will say you can definitely tell that this recurrent BV market hit probably like 6 years ago because it became patients were like able to find boric acid suppositories like on Amazon easily, whereas before we were trying to like send them to compounding pharmacies to get them, and now you can get a bottle of 100 from Amazon for like $10. None that's regulated, but at least it's accessible for patients who are motivated and want to try it without it, having to go to a compounding pharmacy or something before. I don't see any more questions in the Q&A, but I'm happy to answer more or hear more about.
Yeah. Yeah, if anyone wants to come off mute, we have a few more minutes. Thank you so much, Dr. Schwebke and Dr. Bukowski. It is fascinating just to listen to y'all and your experience. I really enjoyed this presentation.
I will just say that the work that we're doing, again, I know vaginitis isn't always the sexiest topic, but it is, again, I feel so strongly about it being such an impact on people's lives, and having clinicians who are able to talk to patients about it, reassure them, help them understand what's going on with their bodies, reassure them when their vaginal discharge is normal, because a lot of people don't know what that is. It's just, it's such important work for people to understand their bodies. And so it's nice to be able to talk about it and with such an expert on it as well. Um,
Yeah, I used to, when I was working in the clinic, the nurses kind of get burned out a lot of times, and I don't blame them. So every once in a while, she would say, "Oh, it's just BV." And I would say, "No, it's not just BV. You just did a really important thing for that woman and for public health in general to try to, boost them up." And it's true, to let them know that they're doing some really important work, really important.
Yeah, I completely agree. I mean, about 21 million women a year with just BV who take time off of work and have to interrupt their lives to see a provider, get treatment. I guess the one thing I didn't talk about, Nat, that I'm interested to hear for those of you who have any kind of telehealth capabilities or using telehealth, I do kind of wonder how NAT testing will potentially improve access to accurate remote testing for people. I mean, obviously depends on approval of the assay and things like that, or for people living in rural settings where maybe getting to an office is not accessible, but getting an accurate test as opposed to empiric treatments over telehealth will maybe improve accuracy as well. Because you know that there's so much empiric treatment from patient messages coming through, hey, I had BV again, or telehealth visits for patients, are self-diagnosing, and providers like Shirley just write the script and just probably make it even more confusing.
And just a flag for you all, someone commented, this has been extremely informative and helpful. Thank you. So I absolutely echo that. Thank you both so much. Just a reminder to our attendees, this was recorded and we'll send it out afterwards. So it'll be available for a rewatch. And if you do have any other questions, if Dr. Schwebke and Dr. Bukowski are open to it, we can also send out contact information along with the recording. So you are welcome to reach out directly to any of us. So thank you all so much for being here and have a great rest of your day.
Thank you.
Thank you.
Thank you.